for this panel discussion, I invite Dr. Pradeep Goyal sir, Dr. Gambhir, Dr. Vitali, please have your seat. In your Indian scenario patients, so the first important thing that Dr. Pradeep Goyal sir, that like how skin play a role in prognosis of surgery, because you have a long experience about the Indian patients. Then such type of the patient, yeah, when we have that.
Such patients with a thick skin, it's very difficult to give a good contour and aesthetic outcome for the rhinoplasty. Initially, we have to treat the skin. There is a definite role of isodontoin in
Yes.
initial phase. At least people say that we should use it for 5 to 6 months prior to surgery, then stop for 15 days, and then go for surgery. So that will take care of highly sebaceous skin. And during surgery also, we can thin out or we can remove the fibrofiber tissue, as Dr. Sandeep has mentioned. With the help of that process, we can reduce the thickness, and the additional structural graft is required.
Yes.
For better control.
So, Dr. Gambhir, then what is your message to the audience when you such type of the patient? Then how we counsel, we different counseling rather than other patient?
Basically, patient has to be realistic. They must be explained clearly that whatever we are doing inside, it is the folding of the skin that will give the contour. Because the fold is thick, the contour will not be very definite. So they have to explain with some sort of piece of paper that you use a piece of paper, thin piece of paper and a thick piece of paper. Explain to them how that this contouring is different between those and they can understand.
Exactly. Dr. Vitali, basically, I think you don't have such type of the thick skin patient in your, but we mostly have. So I think how you manage this such type of the pre-operative and the post-operative?
Yes, you're right. It's not my usual patient, but sometimes I perform surgery on patient with extremely thick skin as well, because our country is huge as well, and there are some south region that can give me quite big amount of such patients. But the issue that the third patient, I think, has also disease. I mean, picture, third picture, some disease of another tissues like intermediate tissue or something. I mean, it's disease. It's not like usual thick skin patient. But first two patient and third patient look like usual thick skin patients. One of them Asian and two of them, I mean, this mix of blood. And in my consultation, I always take I mean, additional time for such type of patient to explain, as the previous doctors talked, but also explain that they will get their result not so fast as the patients who already has thin skin or medium skin. They should be prepared for 2-3 years as minimum to get really exact definition and exact results. And also, I cannot imagine, for example, myself that I perform surgery on such patient without good structure for the nose tip. It's very important to give good structure for the nose tip. You can also create good structure for the dorsum, but most important, improve structure for the nose tip. Because of that septal extension graft, it should be, I mean, it must be placed in such type of patient. And also, I found personally for me also very helpful to remove the SMAS flaps that I usually raise and put back on such type of patient. I remove the SMAS flaps because in case of definition, you need not only less subcutaneous tissue, you need also less soft tissue inside the nose tip. And all the distance between the grafts inside the structure, I do use more narrow to each other. I mean, in case then I use, for example, dorsal augmentation grafts, in such type of patient, I use distance between edges, like 5 millimeters, as
Yeah,
I mentioned
yes,
in my
yes.
first
Yes.
talk. And if I make a rhinoplasty with tip, for example, I put the distance between two domes much closer to each other instead of patients
Okay.
this thin skin. It means it should be distance, for example, also 5 millimeters between each domes to create exact position of on the tip after 2-3 years after the surgery.
Really, so it's a very important message by Dr. Vitali also. Then in the first two patient and the third patient, when a patient come in your OPD, then first you identify that is there the real thickness of the soft tissue or is it disease of the skin? Like the third patient that have the disease in the skin. So if you attempt the such type of the patient in an active disease, then you have a create a problem for you. So such type of the patients, you refer to the dermatologist, first control the disease and then you do the surgery. And the counseling part is important, particularly because patient have a lot of expectation from you. So at least you ask then after the surgery, patient just for the final result, it will take around the 2 year to the 2.5 years. Otherwise, the patient create the nuisance. And these are the some. This is the method by which you can debulk your thick subcutaneous tissues. It's an easy method just by a cartilage holding forceps. You give a counter pressure and just you plug it the thick subcutaneous tissues. But again, if the skin is thick, the dermis part the thick, and the patient have excessive fat, then you use the defattening. But if the patient have a diseased skin, then you cannot correct by this way. Some people they make the incision also in this, but this is the easy methods just for my beginner friends, and you have the less and less chance of the subdermal plexus injury in this case, in this method. So you debulk in the thick skin patients like this. So in the last, when you close your case, then you assess and you debulk your thick tissues. And these are the pulse for the. So proper basically evaluation and the counseling is mandatory. CBS, if the patient have the CBCS overactivity, then you use just like the Pradeep Goyal sir, some retin treatment and proper diet and presence of extra fat, you debulk. And just like the supratip stitch, like yesterday Dr. Vitali did, they also the important. And you use the Kinacort also like Dr. Santadeep mentioned in his lecture according to the need. So this is also a common situation in Indian scenario, again after the thick skin, like a wonderful lectures by the Dr. Gambhir. So Dr. Gambhir, then the basic in the approach basically, particularly we can say that what is the different plan than the usual rhinoplasty, and then the what is the different plan for such type of the patient at the opening of the nose.
So the main thing is that you have to lengthen the columella.
Yeah.
I think, whatever you do, if you have not planned for the columella lengthening, the result will be absolutely not natural and not very good. So lengthening has to be planned before the start of the procedure. So how you do it, it depends. There are 2-3 ways to do it. The usual way which I am using it basically VY-plasty using a Cronin flap, taking from the vestibule, or you can take it from the upper lip. The upper lip is good length is
But
there.
can we do it by the usual incision?
No, it's
No,
it's not possible.
It's not possible. It's not possible. So, Dr. Vitali, that how can we manage by this short columella problem at the time of the after the incision when we close the case? So, what is your planning for that when we make the closing?
First of all, I always use RIP for such type of patient, and I use additionally maxillary graft, premaxillary graft.
Okay.
quite big from the rib for such type of patient. And also, I prefer to use septal extension graft for the rib, and it gives possibility to tense the skin around this septal extension graft. In case then you additionally need skin, I perform very wide mobilization of the tissue to get skin from the all areas. And in order to improve the length of columella, you can use additionally flaps from inside the nose. It depends on the case, but in most of the cases, it's enough for the tricks that I mentioned before. Very good structure from the rib, and plus very wide mobilization of the tissue of the nose. Yeah?
Pradeep Goel, sir, that when we suture V2Y manner at the time of the closing for getting the length of the extra columella skin, then some junior colleague asks, then we face the problem how we close it, because that is not exactly on the proper symmetry. So what is your message for that?
When you are exposing such type of cases, either you have to plan well in advance your incision.
Okay.
Normally we for the exposure we give incision in the middle of the columella, or at the narrow width of the columella for opening. But in such cases, either as Dr. Gambhir has suggested, we have to go for a VY advancement from the lip, or we can convert VY advancement into trifoliate flaps. We can also harvest 2 flaps from the nostril sill. So all 3 can be adjusted, and we can get extra length for the columella,
Okay.
and then the closure will be easier.
Okay.
I would like to add something. Just
Ye-
take
yeah.
a look on these soft triangles. They're huge, yeah, and you can get real amount of the skin for the columella from this soft triangle if you use very stable central column, good support from the premaxilla. You just need to advance the skin from the soft triangle because they're huge. Yeah, you can get additionally 3, 4, 5 millimeters of the skin for elongating columella in these cases. Yeah,
We do the pre-maxilla augmentations, but I just make an incision on the like the labial mucosa and just make a space, and we put a graft. At the last we do the pre-maxilla augmentation by some diced cartilage, or put a big piece of the cartilage also. But the main problem is the lengthening of the columella.
Yeah, I mean, just take a look on their soft triangles. They're huge. Yeah, and because of skin from the soft triangle, you can get very big amount of the skin. You just need to advance these flaps. You just need to reduce the size of the soft triangles, and you can get the length of the
Yes.
columella. In most of these cases, there are much more problems than you already had the scars in this area. That is a real problem. When you have scars, you need to use flaps.
Yeah. So look, this is the main problem. Everyone, my junior colleague asked me, then how can I close it, because the incision is wrong. So they have the problem in the closing, because after the lot of augmentation, we need some lengthening of the columella. So for getting the extra length, we just use this type of the incision, and then in V2Y closure. But the important thing then first you make, when you put some graft, septal extension graft or something, so first you make a suture just in between the muscles after the undermining, and then you suture the skin. At that time there is a little bit teethering, but after later when the skin is stretching, then the settle down the all things. So proper evaluation of the length of the columella and counseling of the patient is mandatory, and the length of the columella increased by the V2Y incision. So the most important thing, first you judge that your incision is either this is a normal incision or that is the V2Y manner in such type of the patient. So look that again, these 3 are the operated patient. These all patient are the operated patient, and the patient have the, after the surgery, both patient have the problem. Dr. Gambhir, what is basically problem? What is something wrong at the time of the surgery? Can you comment?
I think the scar has been made just a horizontal scar with there is no continuity in break. There is no break in the continuity is there. That is why it's contraction. Basically, the scar contraction is the main problem.
Definitely, Dr. Vitali looked at the patient, some in the basal view, and the upper patient looked at the patient have some scar.
But in my opinion, they're different. First of all, they have different skin and different problems. And if we discuss, we can discuss each patient precisely. But if we talk about first patient, for example, she has very thick skin, and I think the problem was not good support for the nose. Again, we just talked about that. We need to use very good, very strong grafts to tense the skin and to get I mean, proper construction of the superficial tissue on the that scars, on that construction, and also because of the not enough support for the lower walls on the nose tip, she got parenthesis deformity on the both sides. Also, there is notching on the left side, and there is significant alar retraction on the left side because of, again, absence of good support in this area. To treat such problems, I usually use lateral crural struts plus lateral crural remnant grafts or remnant lateral crura together. In some cases, additionally, I use articulated alar rim grafts to fix this problem. Some cases needs also additional lining from the composite grafts from the ear, because after the tension of this skin, after creating the good skeleton of the nose, it can be deficiency of the skin. Also, massage cannot help to treat this deficiency, especially inside. You need to use additionally composite graft to treat such type of notching and alar rim deficiency.
So really look that in all picture, this patient is post-operative patient, and this patient is mostly problem due to the incision related, and this patient is operated in my earlier meeting by a good faculty, and bad luck, the both patient operated by the same faculty. So look that the patient have this scar, and the left side, the soft triangle is the notching. And again by the same faculty, the same patient, look that they have this scar and the notching. So this is the incision difference like we discussed. When you use the inverted V incision, I never saw in my life of the 10-12 year that the patient have incision related problem. But when you have the stair-step incision, then you have such type of the problem. Because in stair-step incisions, the upper part of the stair that is nearby the soft triangle, so you have some asymmetrical such type of the scar. So such type of the things, I think you avoid by your good meticulous technique. And look that in this patient also by a beginner surgeon, so the problem in this patient, rather than marginal incision, he used the rim incision. So the patient have some, this is a medical student, so the patient have some scar on the nose. So such type of the patient, because the management is difficult, so you can use the incision is meticulous techniques, and just after the revising of this, but still the patient is improving, but the incision is that visible. So when you use the incision, then proper evaluation is mandatory. Now, some have this post-septoplasty deformity. I think all of you face in your, Dr. Gambhir looked at this such type of the patient, I think in your common in your OPD. So what is something wrong at the time of the surgery with the surgeon?
The main thing is basically saddle nose deformity. The septal support which the surgeon has left was not sufficient enough to support the whole nose, and it has just collapsed. Okay, so basically is a over resection of the septal cartilage, that is the main problem, and not maintaining the support. That's the main issue with these patients.
Dr. Vitali, can you also have in your OPD such type of the patient secondary cases?
Yesterday we had some type of this patient.
Yes.
It's usual patient for
Yes.
us after septoplasty, after losing the support of the caudal septum, especially in men, the thick skin, we can easily get such problem. Yeah? To treat it, yesterday I explained how I do that.
So, for such type of the patient, for managing either the septal extension graft or columella strut, which is your best graft, sir? Dr. Vitali.
I use septal extension graft in 95% of all my
95%.
cases, and especially in such type of patient. I don't use columella strut. I think it's wrong decision. Yeah? No. It's, high septal, yes, high spreaders, it's very easy. I mean, to think about that, you just need to use your own spreaders little bit above the septum. It's the same concept like usual spreaders, but little bit above. Yeah? I mean, of course, it works well for such type of patients.
So, it's an important message to my junior colleagues. Yeah, boss.
Yeah.
Centimeter. Yeah.
Entail is how to treat that and how not to have
That means after the septoplasty, patient have?
remnant deflection because you have left the caudal septum.
Yeah.
So how not?
No. That means first you judge. If you have some excess amount of the caudal part of the septum, definitely you trim that one. If you have a excess grown of caudal part of the septum, and if you shifted just behind the medial crus, then obviously it create heterogenic deformity. So first you judge that if you have excess amount of caudal part of the septum, and then you little bit trim it, and then rest of the part of the caudal septum, then you shift it behind the medial crus.
No, I am not shifting it behind the medial.
Okay.
Sometimes you leave the caudal part of the septum.
Yes.
To not to have this kind of setting.
Yeah. Okay. In the normal case.
Yeah, in the normal
Okay.
case. But after 2 to 3 months, there is deflection again in the nose. So how to prevent that? That you should.
I think when you make a Killian's incision, that should be little bit behind. That's the strip that should be at least more than 1.5 centimeter. I think doctor.
I think there's a point that has to be taken. Like you, as a ENT people, you people are lot of doing septal surgery, just simple taking out the deviated part of the septum. Nowadays, there is no surgery like septal, just taking a small part of septum. It is a septal framework that you have to consider as a whole. Okay, either you do a septal framework surgery as a whole, or you don't do a septal surgery, small surgery. There's no concept like.
But he discussed only the septal.
I'm just pointing on that part. But there is always a deviation on the caudal end as well as on the dorsal end. With normal septal surgery, you cannot handle that part. You're not going that part. You're not taking it out because you're not straightening it. So there will be always a deviation. So you have to take a septum as a whole, not as a part.
Okay, so you mean to say that first we should outline the entire septum and then deal with it.
Then deal with it. Only then you can do it. Either if you need on the table, you need to put a spreader graft on the table, you put it. You cut the septum extra part, cut it there. You do as a septal framework surgery now, not as a septal deviation surgery.
So again, just the post-septoplasty deformity, I think usually you face all of in the OPD. Dr. Vitali, that in such type of the patient, what is your important planning just for correct management of, what is your important message?
We already talked about that. It's also saddle nose deformity, but it can be because of previous surgery, also can be because of trauma. Yeah, it's two reasons usually for such type. I didn't see congenital such type of problems, but most of them trauma or previous surgery, and in most of such cases completely destroyed part of the septum or completely destroyed part of the upper laterals. So you just need to recognize what happened and fill the middle third with appropriate foundation. I use high spreaders for such type of deformity, plus additional gap graft between them and some small or little bit bigger soft graft on the top.
What is your message, Dr. Gambhir? I think you also find in such type of the patient in your OPD. It's a common problem.
It's a common problem that everybody is facing, as maybe due to some infection, maybe due to trauma, maybe due to any iatrogenic causes. It can be due to anything. The concept is very simple.
Yeah.
Treat it, to treat it as a whole, treat it with some solid object, means you need a rib for this. You cannot, there is no remnant septum there. Take a rib graft, use it as a spreader graft, use it as an augmentation spreader graft or a functional graft, but take a graft.
Yes.
You need graft for this.
So the important message that when you correct such type of the patients, rather than you never use the shortcut. They, sometimes again when they revise, they put a small direct part of the cartilage or something. The foundation is first you make the separate, like yesterday did by the Dr. Vitali. You need the good spreader graft and you make a good mid-vault foundation, and then you should correct such type of the case. Mid-vault foundation is important just for correction. Either you use the spreader graft or the high spreader graft. Without making the mid-vault foundations, it's very difficult to correct. हाँ तो सर माइक देना उनको.
Good evening, sir. Just wanted to ask for this augmentation for saddle noses. What will be the suturing point for the spreader graft in the cephalic position? Where exactly, especially high spreader grafts?
Yeah, Dr. Vitali, that means he asked then when you use the high cephalic, when your upper end of the cephalic graft you put in the between the bone. So how the suture he asked then?
In most of the cases, a suture is drill hole to the bones. It's just one hole through the bone. This piezo drill, you can use electric drill, and you can suture this one suture. You don't need, but it's very important. It's key to fix between the bones. Yeah, you cannot put them just on the septum because they are huge, they're big, and they can be, deviated on the both sides. It's very important to fix them to create two pyramidal osteotomies, minimum 1 centimeter length, and put them very firmly inside these slots. And fix with one suture, PDS suture usually.
So how much inside of this bone, around how much millimeter you just so?
Minimum 1 centimeter, minimum.
Minimum 1
1
centimeter.
centimeter of the
Okay.
spreader should be fixed inside the bones.
Okay.
It should be again, because bone is foundation, you should fix your foundation in the middle, this is the stable foundation of the bones. But in such cases, I highly recommend not to perform complete osteotomies. When you perform complete osteotomies, again, you will get instability of the whole foundation. Because of that, I use rhinosculpture, incomplete osteotomies in case when it is necessary in such cases, because you saw that it's quite wide bony dorsum. If you break completely the bones, and then you fix in these completely mobilized bones your middle third, you can get unpredictable results. You need something stable, like house. If you build house, second floor should stay on a very stable surface.
Perfect.
Yeah, it was my biggest mistake when I did complete mobilization of the bony pyramid, and then I fixed something stable there and got unpredictable results.
That is the perfect. Thank you. And now look that this patient operated, first operated, and then the patient have a such type of the problem, and then again operated by a surgeon, and then again the patient have the same problem. So what is your expert opinion, Dr. Gambhir?
I think the surgeon has used a solid rib graft
Yes.
over the dorsum just to augment it and make it more straight. Without, there are two problems with this. He must have not corrected the deformity, underlying deformity. Secondly, the warping of the solid graft has occurred.
Okay, Dr. Vitali, just in such type of the patient, then what you recommend then? Just we use like some long piece of the costal cartilage, or what is your message then be used by after block cutting or something?
Well, there are different ways how we can, augment such dorsum after removing the implant. But it's very important to understand that we should fix implants. We cannot put any implants without fixation on the dorsum, because Another way you can get such type of problem, because most of the surgeons, they create narrow tunnel and put their firm piece of the rib without appropriate fixation. If you take a look how Dean did it, yeah? For example, Dean Teriumi, he always creates space, fix periosteum or periochondrium to the inner space, then use key wire for that. I mean, it should be fixation. It is the main issue that when you use any grafts on the top of the dorsum, you should fix it very properly, because any implants or grafts what place it on the dorsum with time can be dislocated, like in this particular case. I mean, doesn't matter what type of graft you use, doesn't matter how do you do it, but the matter how you fix it finally.
Yes.
If you fix it properly, such type of result will be much less. Of course, warping is a problem of the rib cartilage.
Yes.
Because of that, I use, for example, composite augmentation. That means foundation, rib grafts in different direction, and then soft tissue. But it's also I used many type of solid grafts in difficult augmentation cases, and I didn't get so many, I mean, dislocation. Here is not only warping, here is dislocation of the
Yes,
implant.
yes.
Yeah, I mean, just think about fixation, how to fix your graft on the top of the dorsum.
So it's really important message then how you fix your graft, because warping is a property of your rib. So you use the different type of the basically all measures, just prevention of the rib, just by the sequential intraoperative carving, balanced cross sections, or some ionizing gamma radiation, also some the Turkish delights and the Namaste technique of the Dr. Kapil's. But you never use like the long piece of the, because when you use a long piece, then you have a more and more chance of the dislocations and the warping. This is a patient again, so in this patient basically, what is your comment of Dr. Gambhir regarding the deformity?
This patient, if you see from the front view, on the top part there is slight deviation of the nasal bone. The right side is more flattened as compared to the left side, and there's a hump coming to the tip. The tip is slightly overhanging, and columna is basically columna is also having tip is drooping, and this is the main deformity, and slight deviation is there in the center part.
Yeah. Dr. Vitali, that how you message that how we manage such type of the sub overhanging columella?
I think in this tip, not only hanging columella is the problem. The problem also is some type of nostril retraction, alar rim retraction. And we should treat both of the problem. I mean,
Yes.
we should reduce the length of the columella. And together with that, we should create position of both ala a little bit more caudal. Yeah?
Yes.
There are different ways how to move ala caudally, but we should think both. Yeah? In such case, you even get real improvement. In case if you just short the columella in this particular case, you will get little bit shorter nose, this over rotation tip, I mean, and will be anyway some type of alar retraction. You just should look at the axis of the ala. It looks like Chinese cap.
Yes,
Yeah?
yes. So basically the patient have a overhanging tip, overhanging columella. So in such type of the patient, just reduce, we use the Tangin groove techniques. So we can reduce this axis columella show. Again, this is a patient that the patient nothing problem regarding the functional aspect. He have only the cosmetic issue. Dr. Gambhir, what is basically the tip deformity? What part the patient have the problem?
Patient, the main problem lies on the tip part, and she had a boxy tip.
Yes.
Very broad tip is there, and columella as present seems to be okay in the right place. The tip part that needs to be taken care of, and you can take care of the ala. The ala, you see, ala is very thickened,
Yes.
and they are fully. You can easily fully see the ala margins, and they are very very broad, and they are not in the same line, and the lines are also different. They are slightly both the caudal and cephalic end they are curved. They are on the same plane.
Yes. Dr. Vitali, there is any other options other than the cephalic, like the without lateral crura treat? We have any other options to treat such type of the patients?
Just we should take a look what the problem she has. She has a significant asymmetry of the columella middle crura as well as a boxy tip deformity,
Yes.
as previous doctor told. But what does it mean, boxy tip deformity? It means that at the same time short axis of lateral crura moved in two directions. It's not only convexity, it's convexity on the central part and concavity in the lateral part of the lateral crura. To treat such type of deformity, it's very difficult to use only simple techniques like suture techniques or just removing a part of this lateral crura. You need to put something below that. You can use cephalic part of this lateral crura to move under this lateral crura to create surface, or you should use lateral crura stratigraph, because without that you cannot get really smooth surface, flat surface, because there are two deformities at the same time, convexity on the top and concavity on the lateral part. And you need to flat. To flat you need to use something cephalic part of this lateral crura or lateral crura stratigraph.
Perfect. So we reposition of this lateral crus, basically after the lateral crura reposition, we reposit just on the lateral canthus. So basically this is the cephalic malposition of the keys. And when we shift the lateral crus position, then that should be exact on the around the 45 degree from the midline. This is the important thing. And this is the, I think, the last patients that such patient have a history of surgery for the flat dorsum. So Dr. Pradeep Goyal sir, what is your opinion for this patient?
Basically, it's a midline cleft.
Yeah.
You can see there's a depression in the frontal area, at the root of the nose, and the nose seems to be bifid. Actually, it needs open rhinoplasty, not just simple augmentation of the dorsum, which has been done in this particular case. That's not going to take care of the whole deformity.
Dr. Gambhir, any comment? A patient have history, once he operated, and after the surgery, he have such type of the picture.
Definitely some implant has been put or rib graft has been put, simple rib graft. I think that the implant is there because it has thinned over the time. Normal authorization doesn't thin, or it has been placed very superficially. And she has definitely a bifid type of nose and with central cleft. That needs to be corrected. Frontal nasal base is very, very broad. You can see there's a very wide width is there, and it has to be a telecanthus type. It's just like a telecanthus type of deformity is there.
Dr. Vitali, what is your comment for this?
It's not easy case, this, in my opinion, artificial implant on the dorsum. And to correct such problem, you need to do it in one stage. I mean, you should remove the artificial implant and use some type of, your own tissues like rib and some soft tissue on the top. I mean, it's significant reconstruction of the nose dorsum plus reconstruction of the tip.
Yes. So it's a very important message. Then this patient is operated, patient have a flat nose. So this is the important message to my junior colleagues. Then your examination part is important. When such type of the patient is either you attempt, then you complete exam. This is a teacher cleft patient. So this patient, when I open, then I find that there is a complete, first I earlier surgeon used a big graft, and there is a slot between the dorsum. So the upper lateral is completely inversion in the two part, in the medially completely, the upper lateral cartilage, and he put a graft between this slot and nothing to do. So then after the surgery, then there is no osteotomy work. So after the osteotomy, we correct the narrowing of the bony vault, and then we remove this graft, and then just we reconstruct the upper LR cartilage, and then we give some reasonable look. So it's an important message when you attempt the such type of the patient. Then proper evaluation of the nasal framework is mandatory for a successful surgical planning. And because such type of the patient is not easy case, just like Dr. Vitali, you need to change the complete 3D framework. Dr. Vitali, I think about the management of this patient.
Can I see another views? Side view, base view,
Uh,
something like that.
I have only in my picture, this is the two views.
What are the complaints?
Is regarding the complaint regarding the tip. Nothing. Functionally is good. He's not happy with the tip.
He is not happy with the tip because of thin skin, because of aging process in this area. Plus, I think, in my opinion, because I have plenty of such patients, plus concave deformity of both lateral crura.
Yes.
To treat concave deformity, there are different ways as well. But I prefer to use lateral crura strut grafts. In some cases, I do flip-flop. I mean, I change the position of both lateral crura from concave to convex. In such cases, together this lateral crura strut grafts, it gives very good surface convexity on both lateral crura, but sometimes you just need to put some button graft on this area.
Yes.
It depends on the case, but I mean, it's usual. I mean,
Yes.
thin skin plus concave deformity of the lateral.
Yes. So basically this patient have the problem regarding this lateral crura part. Basically this is a paradoxically lateral crura deformity, and rest is okay. So just by the flip-flop techniques, after the flip, the patient is happy because he correct the tip problem. We correct all these discussions. This is my last slide. So I just asked to my panelists, then they have a long experience. I think in the earlier periods before to the Piaggio, Dr. Vitali, you used the osteotomy by the conventional methods. So there is one is the external and another is the internal methods. So just your comment then, does it really affect the prognosis if you use the internal continuous or external perforating?
Actually, I don't know what type of better, because I read different papers about that. It's like competition always, and panels about that, what type of better. But I learned personally from Gubish, as many of you guys, because Wolfgang has visited us since 2002,
Yes.
2003 year, and has visited us a lot. And he was my first teacher, and I started to perform my osteotomy using the chisel, I mean from outside, 2 millimeter chisel from outside. I tried sometimes to use internal osteotomy, but I didn't really felt difference between results. I got good results. I was many times happy with my results, but actually I tell you guys that when you start to use Piazza, you will feel something new, I mean, in your results in your life, because it's next step. You can not only treat the bones, you can change the surface of the bone. It's big difference between that. It's not only osteotomy.
Yes, yes. Quick comment by Dr. Pradeep Goyal, sir. Either about the external or internal.
Usually I had done internal, don't have any experience of external one, and quite satisfied with the internal osteotomy.
Dr. Gambhir, you find any scar problem by any patient by the external?
Never.
Never.
Till now, never.
So it's really important message that either you use the internal or the external. The important thing that you correct your deformity, and there is no such type of the problem. So again, thank you so much. And there is no standard rhinoplasty. By finally, the surgeon can select the best incision approach and technique according to the deformity to achieve the desired surgical outcome. Thank you.